So we continued that piece of work looking into the trauma history of injection drug users with a study on the NAOMI sample. The NAOMI sample is a group of marginalized long-term drug users that were part of a treatment program, heroin-assisted treatment, a major interest of mine. And we examined the childhood history with an instrument called Childhood Trauma Questionnaire, and we associated that with an assessment of psychological distress. And this is what we found. I think it's also, okay, I think I don't want to get used to those numbers, really. It's really embarrassing. If you see the level of emotional abuse in their childhood, kids experience, is 69%. Emotional neglect, 80%. So if you refer to the importance of attitude of really supportive developmental area, also to develop the biological prerequisites to really grow up to function as a human being, then you probably imagine what impact this has on the future of those individuals. And sexual abuse is very often also a very significant piece. This continues in re-victimization. Those people are living a life of trauma. It's not about a single event. That's important to understand, and that's important to study. You can't tear apart, just study heroin use or intravenous drug use on the one hand, ignoring the trauma part or ignoring the other pieces I will show you in a second. So if you look at this is the green line shows you along the different dimensions the syndrome checklist is showing. The green line is a late onset of injection and heroin use. The red and the blue are early and very early. So what you see is the later they start with their injection drug use, the higher the level of psychological functioning. So this is also important. It really makes a difference also if someone starts with 13 or if someone starts with 23 or with a more stable background. So this is just a picture to show you how the reality looks for this. This is a lady with a bipolar disease and a heavy stimulant use, living again in a single-room occupancy room. It's one of my favorite pictures because it shows really somehow how entangled all those different pieces are. And another vulnerable urban population we're looking into are the homeless. Again, homelessness is it's very rarely a chosen lifestyle. It's very often a consequence of all areas of stress, and very often a consequence of severe trauma. What you see here, we did the same thing in the BC homelessness survey, and what you see here, nearly 2/3 experience in the childhood trauma questionnaire, 2/3 experience emotional abuse. The male a little less. Physical abuse, both genders experience on the same level. The sexual abuse in the middle is more than 70% among female participants. And emotional neglect and physical neglect is nearly comparable. But the important is, that's real life. That's the average. That's the normal homeless experience. And this is not an exception. That's important to keep in mind. That's not about, I'm not trying to label them. I try to understand the needs, because without addressing it, you're not able to successfully support any kind of recovery. Okay, and last not least, so mentioning that I'm involved with Burnaby. This is very interesting. It's going again through all levels of psychological distress. If you compare the blue bar, that's the Burnaby population, to the red bar, it's acute care population, to the green bar, that's a population control, you see a dramatic, very dramatic, significant difference with those people. And 2/3 of the people came to the Burnaby Center for Treatment and were homeless before. 2/3 were homeless before, and they were not cared for. And actually, we have a very limited capacity comparing to the needs in our province. And again, we find the same level, dramatic level of early trauma we need to address. And that's really important, and it's really an interesting question, how also to use biological tissues and techniques and others, really to show how things are interfering, how they're changing, and how to address them as part of a treatment program that's really effective. And now coming also to the question of severe mental illness, in the Beasley Homelessness Survey, we did a quite sophisticated assessment on the different syndromes and diagnoses. And I can't walk you through, but what you see in this sample of homeless people, 500 homeless people in British Columbia, what you see is a high level of mood disorder, 45% with the experience of a major depression. I was very impressed by the number of bipolar clients with a 44 with a manic episode too. So the average lifetime prevalence of schizophrenia is 1%. So it's 27.2. Those are not estimations. Those are not just a subjective whatever impression. Those are really state-of-the-art assessed. And this is also a very special feature of that piece of research. So we can really see there is a close entanglement overall dimension on the trauma dimension and the mental health dimension and the polysubstance use that is somewhat contributing to a social marginalization and homelessness. And we will only be able to address that more sophisticated if we more integrate into a common approach. So not everything that counts can be counted, and not everything that can be counted counts. We have to find out what counts, and therefore we need really a more close understanding. So I have a few minutes. So if you look from a lifetime perspective, and if you really consider how long it takes our system to respond to the misery, so if it's starting with early trauma, as I hopefully could show you, it's a symptom for a very for an unsupportive developmental environment. That's an important piece, right? It's not the single event. Sexual abuse is awful, but especially showing that the family is obviously not functioning as it should function. And this has all different biological impacts. So as you already showed around neuropharmacology, neural functioning of people, and it has a severe impact even before in pregnancy. So just to mention one thing, in the Battery Center, we looked especially into neurocognitive functioning. We found only 25% of our clients had a normal level of cognitive functioning. Imagine what the consequences are for the overall treatment system. If you go through, probably our system is not responding to any of those things. There's no support for the families. The only really functional program, the She-Ways and Peer Square program there, gives only support to addicted mothers for 18 months. So what can you do in such a very short period of time? And it would be a very brilliant investment and a just absolutely brilliant idea to give more support to the pregnant women and to the young mothers to navigate through the system and create a stable environment for their kids later on. And it's going on and on. It's going on, and then in the end, a lot of those clients we find, we end up in the prison system.